Good afternoon, everyone, and welcome to your second webinar in a day. If you've already joined our earlier one, my name is Richard Todd. I'm joining you from Kaleidoscope, where we're going to spend the next hour talking about system change in health and care worldwide, a crash course, so to speak. Delighted to have with me
Anna Howells,
Angus Ramsey,
and then from Copenhagen.
I'm Christian Nielsen from Copenhagen, Danish regions. I will do more introduction later.
And Vancouver.
Alan Best, Vancouver.
Alan, Christian, Angus, thank you so much for joining us. I'm saying this afternoon, Alan, it's what's it, 7:45 with you? This is
just after 8 a.m.
Christian and we're both very grateful, but Alan, I suppose you get bonus points early on for joining us at breakfast time. Thank you very much. This webinar is part of a series which Angus will talk a little bit more in a second, but it's all about trying to share learning and perspectives across boundaries. In the NHS, we talk quite a lot about system change, possibly within one particular clinical specialty, or if we're feeling bold, maybe two. Purpose today is really to think beyond and think about what we can learn internationally. So we're going to be hearing from Christian and Alan, and Angus is going to be giving an overview and some link back into your work at UCL. But as well as those presentations, today is very much a discussion, and we'd love for you to join in. Anna, how can people do so?
Yeah, there's 3 ways you can join the discussion today. You can post a question or a comment in the question box facilities that should be on your screen. You can tweet using the hashtag #BetterSystemChange, and our Twitter handle is @KScopeHealth, or you can send an email to hello@kaleidoscope.healthcare.
Thank you very much. And if all your tech decides to melt in the heat, we've worked out that it's sunny in Copenhagen, Vancouver and London all at the same time, which is probably some sort of record. But if all of your technology suddenly fails, don't worry at all. We are recording today's session and it'll be available afterwards on the learningfromstroke.com website. I'll also tweet out the link when it's there. Learning from Stroke, Angus, this is part of a wider event series. What is it? Why are we doing it?
Well, thanks, Rich. So yes, this is an event series exploring lessons from our research on evaluation on stroke service reorganisation. The research itself and this event series was funded by the National Institute for Health Research. The research is led by Professor Naomi Fulop, based at University College London, but also includes representatives from King's College London, University of Manchester, and includes a range of academics and clinicians, service users, commissioners, and so on, have all fed into this work. Earlier today, we had a webinar where Professor Fulop, Steve Morris, and Ruth Bowden talked through a number of the key findings from our research. Just now we're going to be taking this international perspective on things, and both of these webinars are going to be building to next week's event where things climax face-to-face in London, where people are going to be exploring how these lessons might be taken forward in the future.
Lovely, and I think it's fair to say, Angus, sort of large-scale change in healthcare in the NHS doesn't always get the best of reputations. It inspires a bit of cynicism. Purpose of these events is really to think about how we can do it better.
Very much so. It's a real opportunity to look at a case where changes have actually been implemented and we've been able to evaluate them, understand how things were done and with what impact.
Lovely, great. Angus, thank you very much indeed. So just as a reminder, so if you're not aware about Kaleidoscope, we're a social enterprise focusing on bringing people together to improve health and care. Host today, myself and Anna, joined by Alan, Christian and Angus, and you can find out more about us at kaleidoscope.healthcare. So I think, Alan, we're going to come over to you for lessons from the Canadian experience. Alan, over to you.
Well, I'm delighted to be able to bring some of the lessons that we're learning here in Canada. I'm the managing director of the InSource Research Group and clinical professor emeritus at UBC. What I'd like to do is to just briefly bring some of the passion that our research group has for this large-scale change so that you have a sense of where we're coming from. I'm going to talk about and highlight some of the key differences between regular system change, if you will, and complex system change, because complex systems really are fundamentally different. And finally, I want to anchor some of these ideas with a case study and some of the ideas that we have about systems thinking tools as we move forward. I'm going to touch on 3 different reports that we've produced. It'll be brief, and if you want more detail, you'll have the URL up on the slide so that you can go afterwards and get more detail. Next slide, please. So basically, our research group is all about helping clients achieve system change. And we try to bring, the next slide, please, the wisdom that our very senior group of people who are former CEOs, deans of medicine, and others to the table to try to look at a more holistic, bigger view of systems thinking and how we can make fundamental changes. Next slide, please. Basically, you need to be thinking about 3 different kinds of systems. There are simple systems, which use well-established rules and achieve fairly predictable kind of results, like a recipe. There are complicated systems, which also have established rules, but they tend to have moving parts that are interrelated, and you have to understand how those parts fits together. Fundamentally, complex systems are really different. They just don't behave the same kind of way. They're self-organizing, they're unpredictable, they change over time. Next slide, please. This quote from Donella Meadows refers to the work she's done. She was immensely influential as a pioneer for several different disciplines following the Second World War. And this slide gives a sense of how the interrelatedness of the parts is important, the fact that they're constantly changing and evolving. Bottom line, we can't solve complex problems by breaking them down into smaller and smaller parts. We tend to try to do that to make it more manageable. It just doesn't work in a complex system. Instead, you have to rely on continuous learning and adaptation and go with the system as it evolves. Next slide, please. Next slide.
This one here?
That one, thank you. So one of the key principles of systems thinking is that you need to have simple rules that really provide some guidance as you navigate through this complexity and this constantly evolving system. So we were asked a few years ago to do a report for the USAID Country System Strengthening Conference, and we tried to summarize 3 different reports that had recently come out of Canada. A Canadian Academy of Health Sciences report on transforming care for Canadians with chronic health conditions, and Snowden's work, which is a summary of lessons learned in 7 high-income countries and how those lessons could evolve for population change in other countries. And finally, we had done a review of a rapid realist review for the Saskatchewan Ministry of Health to analyze examples of successful and unsuccessful transformation initiatives, to synthesize knowledge about underlying mechanisms, to clarify the role of government, and to outline some of the options for evaluation. Next slide, please. Summarizing those 3 different reports, we ended up with 8 simple rules. The first is that you simply have to begin somewhere. There's no one right place to begin with large system change. What you want to do is to tie into ready-made pathways for change by enhancing and expanding on aligned work that's already underway, and then to make multiple efforts to link the things so that they're moving in a similar direction. You have to have a blend of designated and distributed leadership. It has to be top-down, bottom-up to really mobilize the efforts of everyone in changing in a transformative way. You need feedback loops that provide real-time feedback loops and data on how the system's changing, what's working, what's not, and how to improve. Financial incentives are important, and they tend not to be aligned for change. The issue is to look at how you can get financial incentives and new financial models that really drive innovation. Next slide, please. Attend to history. Different communities, different sectors have their own history of change and the kinds of things that work in that context. And what you want to do is to harness those naturally occurring strengths so that you can align them with the changes you're promoting. you have to engage physicians and other health professionals. They're necessary, but not sufficient for system change. And the research suggests that vested interests are perhaps the single greatest barrier to creating the transformative change, and you have to figure out how to do that more effectively. Include patients and families. We all talk about it these days, but our reviews have showed that it tends to be somewhat token. But in actual fact, when we looked at consumer engagement across the system, that was a significant, consistent factor in every country and a defining feature of innovation in most of them. And finally, you want to integrate the services across the continuum of care. The two most compelling, consistent trends for innovation were the integration of services and the strengthening of primary care to manage chronic disease. The next slide, please. We use a second conceptual framework as well in our work, and that's realist theory, developed by Ray Pawson and our senior associate colleague Trish Greenhalgh. What it does for us is provide a way of understanding strategy and improving evaluation, building on the principle that context is everything, and that what we need to do is to understand context at the individual, work group, institutional, and health systems level, and to align those contexts so that they're all pulling together and that we can effectively tailor strategy to the local context. Next slide, please. What I want to do briefly now is to use a case study to highlight some of these principles. You can look at the report for more detail, but I'll touch on some of the key things that we've looked at. It was the provincial goal in British Columbia was to introduce and strengthen 11 evidence-based clinical guidelines. The BC Patient Safety and Quality Council oversaw the implementation. They saw our work as a case study in large system transformation. So the study used a literature review balanced with key informant interviews, focus groups, and a province-wide quality workshop. We conducted interviews with a wide range of individuals, clinicians, administrators, senior executives, board members in all of the different health regions in the province. And then the initial findings were validated with an online survey of a large group of people who had experience with clinical care management. The next slide, please. So the biggest single challenge that we identified was the challenge of building local ownership. And here are some of the simple rules that we found that really seem to speak to this question of how do you go about doing that effectively. It had to do with leadership, communication, aligning the incentives, really encouraging this local ownership and an ability to adapt the guidelines to the local context. Information systems, our standard ones, just don't provide rapid feedback that's needed. And fundamentally creating culture change that would support integrated guideline implementation and collaborative clinical teams. Next slide, please. Putting it all together across the various reviews that we've done, what we find is that there seem to be 4 cornerstones: leadership, community engagement, networks, and a structured process for moving from knowledge to action that really are at the heart of a system change initiative. What you see around that are the variety of specific key success factors that seem to come out across the various reviews that we've done. Next slide, please. So I'm going to close by talking about systems thinking tools. There are a lot of reasons why things like concept mapping, network analysis, dynamic modeling, causal loop diagrams, all of which are tools that rely on this kind of complexity principles. These tools are necessary to really undergird the kind of collaborative change efforts that you're trying to make. Complex transformation really means partnerships across different groups, different organizations, and these partnerships need to develop a shared understanding and the trust. They do that most effectively by working together on something tangible. One challenge is that the evidence base that we're trying to build on doesn't address context. It always has to be adapted by combining what you've learned from the generalizable research with more evidence about the local context and the kinds of things that work here. The community partners need support in developing their capacity for systems thinking. We're just touching very briefly today on what systems thinking is all about. It turns out that it's really hard to break out of our habits and to start to think about the problems in really new and somewhat challenging ways. What the systems thinking tools do then is to develop a shared understanding, to strengthen the existing relationships in the network, to pinpoint priority actions for the local context, and then to develop the feedback loops. Let me close there. Thank you.
Alan, thank you very much indeed. That seems, well, that was a masterclass of both healthcare transformation expertise, but also concision. Alan, you have our commendation on both points. Thank you very much indeed. Just to say, we'll come back. I'm sure people have questions, but we'll come back to you, Alan, after Christian's presentation. But Anna, just a reminder how people can join in.
Yep, 3 ways to ask a question or post a comment. You can use the question box facility on your screens. You can email hello@kaleidoscope.healthcare, or you can join us on Twitter using #BetterSystemChange.
Yeah, thank you very much. And what I think we'd really appreciate from people listening in is how much what Alan set out resonates, or actually what might actually run contrary to your local experience and why. Very much like to hear from you. So Alan, thank you very much. We've ticked off British Columbia, ticked off Vancouver, and we're now going to come across to Copenhagen. And Christian, thank you so much for giving up the time to join us. Christian, I'll allow you to introduce yourself and your work.
Thank you very much, and thank you very much for the invitation for this event, for this webinar. As I touched on briefly earlier, I represent the Danish regions, which are interest organization for the 5 regions of Denmark. We have 3 layers of government in Denmark: the national level, the regions, and the municipalities. There are 98 municipalities and 5 regions. And the region's main task is to provide healthcare to the citizens of Denmark, which is quite the task. And also in order to do this, to build new hospitals. The regions were created in 2007, and following briefly after this, there were hospital plans laid out for a new hospital structure in Denmark. This came out in 2008, and there were 2 main pillars of this restructuring of the hospital sector. The first was a centralization. We were reducing the number of hospitals, and also we were reducing the number of hospitals with highly specialized functions and emergency units. So we were, so to speak, gathering the experts at bigger hospitals. There were also a decentralization pulling the other way, strengthening the pre-hospital effort, and also the role of the general practitioners. And then again, we were also cooperating more closely with the other layer, the municipalities in Denmark. Next slide, please. And to show this transformation, you see here a map from 2007 and 2020, where we will be reducing the number of hospital units from 80 to around 50 units. This has also meant that we are strengthening the emergency care, the pre-hospital effort. We have established a national helicopter plan in order to reach the outer regions of Denmark. This is something that caused great concern within the citizens, that we are reducing the number of hospitals and that we are closing down their local hospitals. So this has been something spurring great debate, but also creating better healthcare for the patients, gathering the experts in bigger units. Next slide, please. And to lay out the basic facts of this change that we made back in 2008, there were created a fund called the Quality Fund, which hospital projects could apply for funds from. It was financed 60% from the government and 40% from the regions themselves. This ended out with 16 hospital construction projects, ranging from renovations of existing hospitals to brand new greenfield hospitals around the countries. It was allocated 5.5 billion euros and was one of the biggest construction projects in Denmark ever. In addition to these 16 projects that are ongoing with the Quality Fund, we have 27 ongoing projects around the country. As I said, this started out in 2008, and we're actually now beginning to see some of the Finnish hospitals, but the last of these 16 big projects will be finished in 2025. So we are still some years away from reaching the goal and really see the results of these new hospital plans. As I'm sure Alan knows more about, and as he also touched on in his presentation, this is not only new buildings that we're making. It's also a whole new culture that we are trying to create with these new hospitals. Next slide, please. This plan that was laid out in 2008 consisted of both criteria for the regions themselves and also for the individual hospital projects. The criteria for the regions was a gathering of the functions, as I touched on before. There was also the pre-hospital effort and the connection to other regions. The individual projects had to rely on their role of the project in the new hospital structure, but also on the possible alternatives that were. And on this basis, there was allocated money from the Quality Fund. There were also very specific criteria. For example, there needed to be a 20% decrease in the bed capacity in the new hospitals compared to the ones that were there before 2008, along with a 50% increase in the number of outpatient treatments in the new hospitals compared to the older ones. And we're actually seeing these years that the goal of a 50% increase in the number of outpatient treatments, we're actually outrunning this, we're exceeding this. So in that way, it has been a success so far, and hopefully it will be even better when more of the new hospital projects open. Next slide, please. As I said a bit about earlier, this is not just building new hospitals. We're also cooperating very closely with the general practitioners and with the municipalities that provide social care to the citizens of Denmark. We're not only building somatic hospitals, we're also building psychiatric hospitals, and in this regard, we need to work very closely with the other branches of the healthcare sector in Denmark. Next slide, please. One of the most important parts of this plan has been a strengthening of the emergency care and the pre-hospital care. It means that there are now in the emergency care unit access to more specialists and doctors, which means that we can treat patients directly in the emergency care unit. It also means there has been a rise in patients that are being treated directly in the emergency care unit. So the latest number I have is from 2015, where around 40 to 67% of the patients were actually being treated directly in the emergency care unit. It has also meant, as I said earlier, that there's now larger distances to the hospitals, which means that we require better communication from the actual scene of an accident and with the ambulances or, for example, or even helicopters to when the patients get to the hospitals. This has meant that we have been improving the communications in the ambulances with the use of new technologies such as cameras that can actually show the doctors at the emergency care unit the accident that is going on at the actual scene. So these are changes that are being forced by these new hospital structures that are spurring up all over the country. Next slide, please. And this slide shows how we are bringing in the specialist upfront upon arrival. of patients. Earlier, you were treated by a nurse to start with, and then you were being skipped out to the different wards where you were being treated. Now we are bringing the specialists to the patients in order to make patient transportation at a minimum, and also to be able to treat patients quicker. This has, as I said, shown some results already. It can be a little difficult to distinguish which is being what the part of these changes can be attributed to the new hospitals and what can be attributed to all the other changes that are being made within the healthcare sector. But we can see in some of the Finnish hospitals that this is making an impact, and we are hoping that it can be an even greater impact once more hospitals are finished out in the regions. And I think I'm running a little bit out of time, maybe. I think I will end here. This last slide was just to show that the connection to other branches of the healthcare sector, that we are making national goals that reflect the movements that are being made within the healthcare sector, and that we have a lot of focuses within both the hospitals and the other parts of the healthcare sector. Hopefully, on your hospitals, when they're finished, we can check off some more of these boxes and some more results in these various categories. But I think I'll end there, as we also need to have time for questions, I think.
Christian, thank you very much. Again, a wonderful run-through of a huge program, and it's wonderful just to reinforce. I think we like to talk about, we need to think long-term, but the fact that your plan came out in 2008, did you say, and your hospitals won't be finished until 2025? That's a decent amount of time, and probably exactly the right amount of time to not only rebuild your entire hospital sector, but also fascinating to hear how that's then leading to changes across the system, which I'm sure we'll come into shortly. Christian, thank you very much indeed. Angus, I'm going to come to you in just a second, and it'd be lovely to hear your reflections on both Alan and Christian's presentations, given all the work on stroke reconfiguration. So some reflections in just a moment, but before we do, and I think questions already coming in, if people want to send in more questions.
Yes, so if we're going to kick off with a question from Daniel.
We're going to remind people how to join in, and then we're going to go to Angus, then we're going to go to questions.
Sure, so three ways you can join the conversation. You can send an email to hello@kaleidoscope.healthcare. You can join us on Twitter using #BetterSystemChange, or you can post a question in the question box facility on your screens, which lots of you are already doing. Thank you very much.
Wonderful. Thank you so much for sending through questions. But Angus, sort of first reflections, a lot there resonating with some of the messages coming through from your research.
No, very much so. I think there were a lot of, perhaps naturally, given that we used quite a lot of Alan's findings to frame some of our work. I guess one question that occurred to me with regard to the sort of 8 simple rules that were presented was the 8th rule being integrating health services or healthcare, and that in itself seems like quite a substantial change, and one that I think that many people would find quite an intimidating one.
It's a simple rule.
It is.
now just integrate.
Another thing that struck me is just the broader issue of sort of building these rules over time, because I think there's been thankfully quite a lot of awareness of this, and people are sort of thinking about this in research. I guess one question would be whether the rules need to continue to develop and how they might do so over time. And I guess another reflection that I had, I agree entirely in terms of the power of context that one sees in whenever looking at major changes of this kind. I mean, I think a particular challenge for people making changes might be, how to actually reach a perspective that gives you a sense of the whole context when it's understood from so many different perspectives and experienced by so many different people. So I guess these are some of the things that occur to me listening to Alan.
Angus, thank you very much indeed. This is a 1-hour webinar, which could so easily be about a 3-week symposium to go through all of the elements. But so before we come to those questions, Anna, Alan, sort of any reflections on Angus's points about, firstly, are these simple rules going to continue to evolve and grow? And then how do you stand yourself at the right perspective to see the whole context?
Yeah, I think they're both really good comments. The first thing to think is that the rules will evolve over time. The fact that they come out fairly consistently across time and across different projects and jurisdictions gives us some confidence that the basic rules stay fairly stable over time, and that's important to know that you can rely on to a large extent. More important perhaps than changing over time is changing with local context. So you saw the example with the clinical care management study I reported, for example, where there are the general rules, but then there are the specific rules for local context that really take it to the next level in terms of understanding some of the details of what you'd put into your strategy. The aligning different perspectives, again, is a critical question. That's why we use systems tools. Concept mapping in particular really helps people develop a common language and logic so that they're all seeing the problem together and have a different way of thinking about it from their own perspective, but a common language that they can use to talk about it and to plan and work together. So indeed, things are going to change, but the conceptual framework that you get from something like concept mapping, the understanding of how organizations need to step up and the different roles they would take and what the strengths and weaknesses are of the existing network, those are the kinds of things that are important, I think, in terms of aligning individual and group effort moving forward.
Okay, so if you are a sort of a healthcare manager leading complex change, it's safe enough to get those simple rules tattooed on your arm, Alan, just for safekeeping?
I do them on the forehead so people can keep in front of them all the time.
Yep. Good.
I think so, but more importantly, there's a significant shift in leadership style so that it needs to be much more collaborative, much more giving permission, supporting people in adaptation and putting things in practice in their own settings. So it's very much not command and control. It's a let things go, allow people to do things in their own way and to adapt, and then to coordinate and support those efforts.
Alan, thank you very much. I can almost hear the sound of our attendees nodding to that point. I'm sure there'll be lots of agreement. Anna, questions?
Yes, we have plenty of questions coming in. Thank you very much for sharing those so far. We're going to kick off with a question for Christian. Deborah, thank you for this one. Deborah asks, does the government expect the money provided to be paid back over time? And does this affect future budget planning? Some trusts in the UK are crippled by the PFI contracts and are struggling to manage this.
Point. Do you want to pick up that one? Second one? Christian, yes.
Yes, there has been very strict budgetary demands from the government. This money that was given out in 2008 cannot be extended. So even if the regions want to allocate more money to the projects, they're actually not allowed to. And also there were efficiency measures that were made once the money was given out. So the project has to be more effective, has to cut down on costs, and there are very specific goals for each project that were made once the money were given out. So yes, the government are expecting some return on their investment in this regard.
Really interesting. Christian, seen as return in terms of improvements in efficiency rather than payback like a loan. It's not that that money has to be repaid by the hospitals.
No, this was actually what was quite unique about this project. It was that this was a fund that was established by the government back in 2008, and that were invested in the hospital construction projects.
Okay. Christian, thank you very much. Like I could hear people nodding before, I can hear gnashing of teeth from people who've had not such happy experience over here. Anna, we've got a flood of questions coming through.
We do indeed. So this is a question for Alan. Dan asks, is all change complex? Or how do you know when to approach an issue as being about change to a complex adaptive system?
It's a great question. It's the simple answer. But the things like sending a man to the moon is complicated, but not complex, because you can understand the rules, and if you follow things and get it right, it's going to work. With a complex system, you really can't do that. So I think the understanding that you need is to look at what's currently going on in the system and whether or not a command and control engineered approach could work. If it's something simple, for example, we've got an RCT result that simply shows that making available to the local physician the list of the patients who need particular kinds of interventions through the day, that can be done. Again, it's like a recipe. It's like what comes out of an RCT. That kind of implementation need not be complex. But as a general rule, if you're thinking about changing the system, you're going to always have to think about it as potentially a very complex understanding, and think about the kinds of challenges you'll face and whether these simple rules apply.
Thank you. So just as a supplementary, that it's, I think listening to your presentation, excellent, but it can appear that sort of doing systems thinking requires quite a high transaction cost, where, particularly thinking about some of our contexts here, change doesn't always get well endowed in terms of resources to think things through. So is it possible to do, I'm going to phrase this crudely, can you do systems thinking on the cheap? Or does it always require quite a significant investment of time and resource?
I think you're making two critical points. The first is that there has to be investment in change as well as investment in services. And if you expect people to do it off the corner of their desks, in today's healthcare, people are so busy doing so much that simply isn't going to work. So it's a critical question to think about what kind of incentives and the sorts of things that Christian talked about in terms of bringing new resources to the system are going to be a critical piece in that. We're just about to begin a project that is going to take these three systems thinking tools I mentioned earlier, the concept mapping, network analysis, and causal loop diagrams, and develop an online version so that communities can take this kind of approach with minimal expert support. I think that additional step in building the bridge between research, policy, and practice is going to be critical. We don't have adequate tools yet to allow people to do it on the cheap. If you want to allow local communities to grab onto it and say, we can do this ourselves. And that is the next step forward in a way, is to make these tools more accessible. And over the next couple of years, we're hoping that we can make some progress with that.
Great. Alan, really nicely put. Thank you very much. Anna.
Yep, we have a question from John. Thank you, John, for this one. And he says, as Alan referenced, context is all. The context here is of an obsession with reinventing the wheel rather than adopting what is already well evidenced. So do you have any thoughts on changing this deep-seated habit?
Can you say the last part of the question again?
Yeah, so just about an obsession with reinventing the wheel, and how to change that habit.
How do you change the habit of this constant reinvention? Our colleague David Hunter in the northeast of England has written a lot about this. There really is an obsession with constant change in the system. I think part of the problem is that people see it as a top-down, leadership-driven kind of a thing, and it never works. So that because they don't from the outset take on the challenge of really fundamental system change, it seems to be a constant going round and round like a rat in a wheel. Part of the problem is that we rely too much on the leadership and not enough on changing the fundamental structures and the barriers in the system. What I liked about what Christian was talking about is a real change in the way that the emergency system is functioning. That really gave a very good example of once you've made some of those fundamental changes, then you don't expect to see the same kind of constant churn that you do otherwise.
Alan, I'm just going to jump in because I think that's a really important insight and applicable to our context, where we are forever talking about the importance of leadership for change. But the subtext is you're going to need to be a really good leader because we've got all of these rubbish processes which you're going to have to manage, rather than actually, can we sort out some of those processes, and then possibly we wouldn't need heroic leaders the whole time to come and sort them out. I think that's a really interesting insight.
Yep.
But Christian, just to play that point back about here, we come up with a 10-year plan about every fortnight, whereas there you've managed to maintain this program already for a decade, and you've still got quite a long time to go. How have the politics been managed in that? As presumably you've had changes of government over that time, but it seems like it's been quite stable. How's that happened?
It's not that it has been a problem-free process. Let me tell you that. Let me start by saying that because the money were allocated 10 years ago and are still being made, the buildings are still being made. There has been changes in the process, and some of the things that we thought were essential for hospitals 10 years ago are now, if not useless, then being redefined what a hospital has to do. So it has been a huge challenge to adapt the different projects within the very fixed budgets. One of the examples that has been a very hot issue with politicians is if you need to have kitchens within the actual hospital. Some regions are having central kitchens that distribute the food out to the kitchens. But as a politician, you want to make the point that there needs to be freshly made food at the hospitals. So the hospitals have had to redefine the plans for the buildings, for the construction projects, in order to incorporate kitchens at the hospitals. So this is something that has been widely debated, and even though you can actually make quite fresh food from central kitchens, this has sometimes been a demand from the politicians. So this is an example of how the politics has played in, and how they need to adapt all the time in order to stay within the budget, but still meet the demands of the changing politicians. And also we hear every year almost, I think, that are these hospitals being as great as we were promised? And we need to actually tell people about the results already being made and the possibilities that are within these new hospitals. Because it's quite easy to find specific examples of something that is not working, and quite hard to make the case for the bigger picture when you're changing the whole structure like we're doing.
Christian, thank you. Alan, it certainly seems like there should be there's space for a follow-up paper to your 8 simple rules about 8 things which will definitely happen, which will come along and make your change harder.
Yeah.
So asking for results too early, politicians getting involved in micro detail. I'm sure we could share some similar stories.
Well, Christian's making a really critical point about the role of communications and an ongoing multifaceted communication strategy that really keeps everybody informed, including the politicians and the general public, about what this is all about and how it's going. There is a lot of resistance built into the system, and unless you can keep everybody on side throughout the process in a constant kind of a way, it's going to be doomed. So that's why that's one of the simple rules for system change. Canada is going to be an interesting example for you to watch over time. We have a federation here where the provinces actually have the authority to manage the healthcare systems, and the federal government can't intervene. And that's one reason why things look different here than in the UK or in Denmark. And as a consequence, there's this constant push-pull around inertia for change. And I think we've been actually slipping in world rankings as of late in terms of the quality of care. And it's going to be coming to terms with some of those underlying structural factors that really make it difficult for the different jurisdictions to work together and to get the job done, that are going to be key to making success.
Alan, thank you very much. Anna, we'll come to more questions in just a second. But Angus, I thought Christian's point about the location of kitchens just reinforces a point Naomi made on the earlier webinar about just the need to prepare in such detail for the implementation of changes, not just thinking about the shiny idea at the front end, but actually how this is going to happen.
Very much so, and I think it speaks to a number of issues, such as having adaptable leadership and leadership that has sufficient sort of intelligence about what the current priorities are and how things might be developing over the horizon, I think. I mean, one thing that struck me as being really interesting was this idea that this policy could be sustained for such a long period without bending, and I still find that hard to imagine almost. I think, yeah, I just found that very, very interesting indeed.
I think if we made it to 17 weeks without a policy changing, we might be doing well, let alone 17 years. Once again, we are in awe of our Scandinavian brethren. How annoying that is, but there we are. Hats off again, Christian. Anna, question.
Yes, before I move on to the next question, we just had a comment from Deborah about leadership, just saying that it has to be the right leadership, bringing people along, listening to everyone who will be involved. But our next question is, in health system transformation processes, how do you get from knowledge to action? And that's a question from Lucy. Thank you, Lucy. So you'd want to direct that to
Alan, knowledge to action.
Yeah, we did a workshop with our UK colleagues a couple of years ago. So it was published in Evidence and Policy. You can look it up. But basically what we were trying to do is to take the current models for moving from knowledge to action, which have tend to be focused on relationships instead of on systems and complexity. And most of the thinking that's out there around knowledge translation, knowledge mobilization, whatever you call it in your jurisdiction, is rooted in this notion that if we can just get everybody working together effectively, that'll do it. And that's obviously one of these necessary but insufficient kinds of things. So there are principles. Some of the ones that we've been talking about are as much true for knowledge translation as they are for system change overall. So creating a shared vision up front for what this knowledge is all about, understanding how the evidence is going to have to be intertwined with data about local context is going to be critical. This long-term strategy is really important that Christian's been talking about and we've been highlighting, particularly in the Canadian system, again, where the provinces control this and there are elections every 4 years and it's going to be bouncing all over the place. We've been talking about conceptually the idea of getting all the political parties to sign a memorandum of understanding for a 10-year block. And some of the all-party structures that we have lend themselves to that kind of conversation. Getting a real commitment that's going to be held up, of course, is another matter. But I think that that is going to be critical for long-term implementation. Some of these system change strategies is something that goes well beyond the election cycle, and we need to figure out ways to do that.
Alan, really interesting. And UK listeners will, English listeners in particular, will know that there's mutterings going on about what might accompany the NHS 70th anniversary shortly, and whether there'll be some sort of long-term plan, whether that will have all-party commitment to it. I think you could find better odds in joining the lottery, but it would be an interesting one to watch. Angus, I'll come for you for questions just a second. But Christian, I was just wondering if I could pick up one point you made earlier, which is the cultural effects of this huge transformation project. How is that being managed? Is that being left to individual regions or municipalities or hospitals to work out what they need to do individually, or is it being done more centrally?
It varies from region to region, but a lot of it is being done in the individual projects. A very interesting case is in the northern region of Denmark, where they have been involving young doctors, and the doctors have actually been given money in order to research a specific topic that has to do with the new hospital and how this will work out in the new hospital. So the doctors are being bought free, so to speak, a single day a week in order to do research within the confines of the new hospital, and how they will how this will change the way that they do their treatment. We had an example of a young doctor who did some research about how the somatic and the psychiatric wards were working together, and how psychiatric patients were also having a lot of somatic problems and how they were treated. So this is a very concrete way that they have been involving young doctors in order to make this cultural change, so that it lives on, so to speak, in the new hospital, and involve especially young doctors in order to make this change. Yeah.
But again, it sounds like creating time for doctors to do that rather than just adding it on to the end of their to-do list. Excellent. Angus, I think you had a question.
One question that occurred to me is you were mentioning some examples, Christian, of some of the things that are going on within the hospitals. I'd like to get a stronger sense, if possible, of how the changes are being evaluated and researched at present in order to develop lessons for other places that might wish to conduct similar kinds of changes.
Mm-hmm. As I said, a lot of the projects have not yet been finished, so there's not a lot of research being done on the results. But we do have groups, central groups with representatives from all the regions that are looking at the results from the different projects. As I mentioned, the government requires us to do quarterly reports from each project, where they are laying out the progress of the project, but also the changes within each hospital. So there are something being done from the central government, but also as the projects progress and a lot of them are being finished in the coming years, we hope to do a lot more research on some of the pillars of the changes that has been made within the structure. We have been building with single patient rooms in all the new hospitals. So we hope to do some more research on this in the coming years as some of the hospitals are finished. But also, as I mentioned, the emergency care units that has been transformed. We went from 40 to 21 units across the country. So we're also looking forward to do more research on this once they're finished.
Sounds like you've got 17 years worth of action and about 100 years worth of research, Christian, to go through. Thank you very much. Time is against us. We've only got a few minutes left. If you've got any last minute burning questions, do send them through now. Anna, questions?
Yep, we have one more question. Thank you, Dan, for this one. Dan asks, how do you measure the efficacy of different approaches to systems change? So, for example, with knowledge mobilization, how do you measure whether attempts to do this through a systems approach is being more or less effective?
It's a good question, and I was going to pick up on Christian's comments too about evaluation. With a complex system, you really need to shift your thinking about how evaluation should be planned. And rather than looking at primarily outcome evaluation, which is so often the case, you need to be thinking about developmental evaluation, the kind of thing Michael Quinn Panton talks about, so that you're building in the feedback loops and understanding the process of change, because things are constantly changing, as much as understanding the outcome. Still important to look at the outcome, but recognizing that a lot of these things are going to take a long time, and we can't wait for that kind of evaluation. So we need more of a ongoing, real-time evaluation of what's working and what's not.
Alan, thank you very much indeed. I'm going to give my fellow presenters here and Christian, Alan, just a warning that as we are coming to the close, just to start thinking about a sort of a single reflection for us to close on. It seems wrong actually to finish a discussion about complexity by trying to do a reductionist think of one thing, but we're going to ignore that inconsistency. One last question from me. Anna, do we have further questions coming through?
No, not at the moment. Oh, sorry, I tell a lie. We do have one more.
Yes, absolutely. Let's go.
So Sam asks, do you have any tips for mitigating cynicism to change, which is applicable to the NHS, shall we say?
Sam, great question. Lots of people really change weary. How do you overcome that? Christian, should we start with you, then go to Alan?
I'm sorry, could you repeat the question?
Sure.
You were falling out there.
No worries. Do you have any tips for mitigating cynicism to change?
From mitigating systems to change. Well, I think as Alan has said earlier, to involve the local level and to really engage people. We're also doing a lot of work on communication. We try to do open house days at the construction projects in order to let the public see what they're actually getting in the end with the new hospital projects. So involve the public as much as possible and let them know that this is actually for their own benefit, and this will in the end make for better healthcare. So I guess user involvement, as I know that Alan is also very involved with.
Alan.
I'll plug another paper that people can look up afterwards, but I mentioned earlier the study we did for Saskatchewan on large system transformation and simple rules. We did a second study for them on culture change. It's published in Journal of Health Organization and Management. And I think basically that's what we need to look to is how do you create culture change at all the multiple levels. Culture change, even within a hospital, is happening within local wards and specific units. The new head nurse comes in for the night shift and the culture changes. And it's really understanding and working with those culture changes at multiple levels. Peter Senge talks about leadership at 3 different levels in a system. The executive support, some kind of a change leader that has that responsibility in the organization, but fundamentally it's creating the leadership at the front lines, the people who are actually doing it moment to moment that's going to drive change.
Alan, thank you very much. We just have a couple of minutes remaining. So again, thank you everyone for your questions. Great and challenging questions for a fantastic panel to answer. So we'll just go around and close with a single reflection from each of us. So I'll start by one time, and then Anna, Angus, Christian, and we'll come to you, Alan, for the last word. So a single key reflection for me is, Alan, I really enjoyed your point that I think when we talk about change, we can talk too much about leadership at the expense of talking about the infrastructure, about the processes, which are equally as important. Anna.
Thank you. My key point was around the role of communications, how this has to be an ongoing strategy and encompass all the different groups you're working with, ranging from politicians to patient groups to frontline staff.
I won't exaggerate it. Thank you, Anna. Angus.
Yeah, and probably in a similar line, the thing that struck me most was how complex changes of this kind are and how multifaceted approach one must take to understand these things.
Thank you. Christian.
Yeah, as you both mentioned, the complexity, but also as Alan mentioned here, in the end, that it's really the front line and the people out there that needs to make these changes. So to go from the political level and all the grand strategies and plans that we have on a national level to actually making them happening out at the local hospitals. That's what I think is key for change.
Thank you. And last but by no means least, Alan.
Well, Christian and I are agreed. We've talked a lot about principles and simple rules and structures and plans. It's about people. And ultimately, the change is all about how do you engage everybody in the system and keep them excited and bought in and actively contributing their own role towards system change.
Alan, thank you. We talked earlier about whether you need to get all 8 of your system rules tattooed. Just remember, I think just writing it's all about people might be a useful shorthand, possibly if you want a tattoo budget. Christian, Alan, Angus, Anna, thank you very much indeed. Thank you everyone for joining. I think it's been an incredibly rich hour. So thank you very much. Just to say what's coming next. So the webinar we recorded earlier on today, all about stroke reconfiguration in London, Greater Manchester. That will be available on the learningfromstroke.com website very shortly. We're running this all-day learning event next Tuesday. It is sold out, I'm afraid, but there is a waiting list. So if you are really keen to come, do join that. And if you want to find out all about this event series, about the research that's happened behind it and the changes, please do go to Learning from Stroke. And so with the time coming up to 5 o'clock for us, 9 a.m. for Alan, I'd like to say thank you so much again for joining. We hope to see you on a future webinar. Thanks very much all. Goodbye.
Bye.
Thank you.
Bye.